Hello, and welcome to the Life Optimizer podcast, where science meets everyday life and where we believe that tiny changes lead to a whole new you. I'm your host, Viktoriya, a Yale trained certified nurse midwife, passionate about holistic health and wellness. And do I have an amazing episode for you today? Today, we're talking about cutting edge research in prenatal, maternal nutrition, ways to support yourself through the pregnancy process, ways to help alleviate symptoms of nausea, vomiting. We're talking thyroid, we're talking hormone function, placental function. I'm so excited to have our guest, Sarah Thompson, on with us today. And before we begin, I do have a favor to ask. If you are enjoying the content on this channel, an easy way to support the work is for you to subscribe to the channel. Thank you so much for being here, and let's get started. Today, I am excited because I'm being joined by the one and only Sarah Thompson of Functional Maternity. She is an author, she's a licensed acupuncturist, she is a birth doula and certified functional medicine provider, and the founder of Functional Maternity. Sarah, welcome to the Life Optimizer podcast.
Hey, Victoria, thanks for having me.
Absolutely. You know, if you had to explain your approach to prenatal care to somebody on an elevator, how would you tell them what you do?
Oh, my elevator speeches are horrible. What I would, I
Perfect,
think,
mine
tell
too.
them, yeah, it's not my forte, but I think the way I tend to explain it is my role and my focus is on maternity care, not prenatal care. And people are like, well, what's the difference? Well, maternity care is the care of the mother. Prenatal care is the care of the baby. And I have found over the course of years of working that the majority of prenatal care is just that. We're thinking baby, baby, baby. And we're kind of forgetting about the moms in this scenario. And my focus is on moms because I truly believe that if moms are healthy and moms are optimized, their babies are going to do great. But if you focus on babies, then sometimes you leave the moms out. So that's my
Mm,
focus. And that's why, when I when I talk about things, I talk about it as maternity care versus I work in prenatal medicine.
I love that. I love that. I think you're absolutely right about that, that we really focus on baby. Everything's about baby, the measurements. Yeah, I love that. That's profound. You worked with hundreds of women through pregnancy. You trained birth providers. Is there a patient story or maybe your own story that really kind of started your journey in establishing functional maternity?
Yeah, so I would say, what kind of pushed me into this realm was definitely my own pregnancy. And I think you hear that a lot with people who get into any element of maternity care is that it was their own pregnancy and birth experience that drove them down this pathway. Now, my birth experiences were beautiful. I didn't have complications. I didn't have issues with my pregnancy. My first was a little bit of a surprise. So I kind of jumped into it going, oh, I should really learn about this, right? This is happening to me in my life. So I should really know a little bit about this. And as I went through that whole pregnancy experience myself, I realized that there were quite a few gaps. Now, my preconception education and my preconception life at the time frame was very much nutrition focused. At the time, I did primarily sports medicine, pain management type stuff. And that's what I was passionate about. Like, how do I optimize people and make them the best athletes they can be, or, get them through pain management recovery and give them the optimization physically. And then I went into pregnancy and I was like, oh, this is different, right? This was something I hadn't even thought about myself personally. And again, my base being very nutrition, that was a big focus of my practice even at that time. I knew that nutrition had to be the foundation of my pregnancy in and of itself. And so I started to ask the questions to my providers who I thought would have the answers. And nobody had the answers other than don't eat sushi and don't eat lunch meat and you'll be fine. I'm like, wait a second. I feel like there's more to this story than just don't eat things that could potentially carry a pathogen. Like, what about the nutrition that I need? Oh, just take a prenatal, you'll be fine. And this is, 17, 18 years ago now. Yes, that's how old my oldest daughter is as of this year, which is scary. And and at that time, the prenatal vitamins on the market and things like that were kind of limited. And even within that limited market, it was slightly overwhelming. there were so many options. And we had some that had, this type of vitamin. We had some that were food-based vitamins, some that had lots of things, some that didn't have a lot of things. And according to my midwives, who were fantastic midwives, I loved them with all of my heart, it didn't matter as long as it had folic acid, right? That's all you need. You're fine. Anything outside of that is just bonus, right? So I started to do my own research. I started to do my own exploration, reading the research studies, analyzing things, picking up textbooks and reading them, right? And what I found on that journey was actually quite mind blowing to me. And I kept thinking, why isn't anybody talking about this? Why isn't anybody talking about the maternal physiology that's happening at all of these steps throughout pregnancy? And why isn't anybody talking about how the nutrition affects me, right? What do I need? Okay, my baby needs a couple of B vitamins. Okay, fine. But what about me, right? Not to sound selfish, but what about me, right? I felt like I was kind of getting lost in that system just a little bit. And I started to talk to my friends and I started to talk to my family members who were having birth experiences or who were, a few years ahead of me in their birth experiences. And some of the stories and some of their concerns that they had brought up to me were kind of, again, quite mind blowing. Like, what? That's how that went down for you? Oh my gosh. Like, nobody talked to you about this? You didn't even know what to expect? And that's how functional maternity was really born, was with this idea of, wow, we have got to start talking about the maternal side of this. And we've got to start giving moms more guidance on how to keep themselves feeling good through pregnancy and not just focusing on, well, you have a healthy baby, right? How about we have healthy moms and healthy babies, not just healthy babies? Why don't we bring that back into the picture? So that's kind of how we got here.
I love that. Yeah, I mean, I think what when we think about pregnancy, we see the baby growing. We're measuring the baby. We're constantly focusing on the baby, but it's like we don't talk about the uterus growing. We often miss the fact that we're making way more blood from the beginning. Moms are feeling exhausted. There's so much happening in the first trimester. Even that belly is tiny, right? Like you don't look pregnant, but so much is changing. The immune system is changing. How do we support that? How do we support the blood
Mm-hmm.
production? What about the placenta that starts to form? That's a whole organ that you have to grow, and you need some kind of nutrient. Something has to, it
Yep.
has to come out of somewhere. That uterus has to expand. There's so much that has to happen in maternal physiology, but we rarely talk about what are the things that you need. So I absolutely agree. um, and as you already said, that recommendation for take a prenatal vitamin and you're good to go, is really lacking at best. What do you think a provider should say? What are the recommendations that you would like add to that, or is it just this big list which we're going to go through a whole plan, but like
Yeah.
besides the prenatal vitamin, do you think at that beginning, that first prenatal appointment, do you think we should be talking about nutrition? I mean, I do.
Yeah.
I talk about nutrition at that very first visit. They're 6, 7, 8 weeks pregnant,
Mm-hmm.
because I think like it's late to talk about it at 40 weeks.
Mm-hmm.
It's we've missed 10
Oh
buses
yeah.
by then. You know
Oh
what I mean?
yeah.
So what do you think, just like an overview of what it should include in that beginning appointment, besides the,
Mm-hmm.
no deli meats and all the no sushi, no raw fish stuff?
Yeah. And it's so much more complex because maternal nutrition needs actually change throughout pregnancy based off of the physiological changes that are happening within the mom's body. And if we want to start with first trimester, I always joke that, first trimester stuff is really the epitome of maternity care because there's not much you can do for that growing embryo because it's kind of stuck in its little time capsule, and until that placenta is developed and we can open up those spiral arteries, you're really not getting nutrition to that baby. So starting a folic acid at conception absolutely does nothing for neural tube defects because you can't get that folic acid, you can't get that folate to that baby. That's preconception work. That egg
Mm,
and that sperm had to have all of that great folate in it during that embryonic development. Neural tube folds are happening at what, 4 weeks, right? That's when we're seeing the closing happening. Most women don't even know they're pregnant as this is happening. It's not until we get to about 8-ish weeks and those arteries, the spiral arteries of the placenta, open up and we have this big burst of blood flow from mom into baby, and we can pull out all of that buildup of toxicity from all that embryonic development and start that cycle. It's then and only then that we can actually start putting nutrition into our babies. Until then, it's all about mama. What's happening with mama? What are we doing there? And the growth of that placenta. The growth of that placenta relies very heavily on very, very minimal nutrition in those first couple of weeks, right? What we need the most of in those first couple of weeks is actually a high amount of carbohydrates. Carbohydrates are going to fuel the cellular development of that placenta, and proteins are going to be the base of the hormones and the base of the enzymes and different things that amino acids become. And then you have the fatty acids and the cholesterol that end up becoming so much of that progesterone and those different hormones that are being produced by the corpus luteum as well as the placenta as it gets developed. And mom feels this, right?
Mm-hmm.
We don't talk about this, but mom feels this and her body expresses this. And we just kind of say, oh, well, that's, I guess we just don't give it the due diligence. We don't talk about how that makes moms feel. But there's a very strong reason why moms crave carbohydrates in the first trimester. And it's like this insatiable craving. And then other things like heavy protein meats, like red meat, seafood, some of those sorts of things become very strong aversions. It's because the body is telling her exactly what she needs. In reality, we just take modern nutrition and apply it and go, well, we can't do that. We can't be eating that many carbohydrates, right? When the reality is that's what her body actually needs at that time. HCG is a hormone. That's the hormone that's being produced by the trophoblast cells that become the placenta, kind of hijack her body. The HCG looks and acts like TSH, thyroid stimulating hormone, and it binds to the TSH receptors on the thyroid and revs that thyroid and makes it produce 35% more thyroid hormones. Well, thyroid hormones rev your metabolism, right? They get that Krebs cycle going. Well, fats and proteins are slow metabolic energy sources. Carbohydrates, those are our quick energy sources. And so you find that the body ends up craving those carbs because it needs it. It needs it for that rapid cellular development that's going to be happening to those trophoblast cells. We're taking a cute little embryo and turning it into billions and billions of cells that's going to grow an entire organ over the course of a couple weeks. That's a lot of carbohydrate need. And I think that's something that I see very, very commonly, personally, with a lot of people who are eating healthy, right? As we get into that first trimester and they're emotionally toiled over, oh my God, like I was doing so good before I got pregnant and I'm worried about the nutrition of my baby and all I want to eat is a bagel and cream cheese, right? But there's a reason for that. And it's understanding that reasoning and that physiology that, again, helps us understand what does that body actually need from a nutritional perspective. Just kind of fun.
Absolutely.
It's often, that's one of the biggest drivers right there of morning sickness, is not
Exactly.
getting enough of what the body needs.
Absolutely. I was just thinking about morning sickness actually as you were saying that, because oftentimes it's the saltine crackers. I mean, protein, we know
Mm-hmm.
protein really helps.
Mm-hmm.
And I tell my patients to do a little bit of protein throughout.
Yeah.
But it's like you said, you can't really get those minerals into the baby. The first 3 months, even the caloric increase, while, it's nice, baby's going to do fine without that extra caloric intake that we really need in the second and third trimester for our moms. But definitely the carb cravings, absolutely, the carb cravings come, and that's like naturally how a mom's body is responding to the hormonal changes, to the fluctuations, etc. So I love that. Absolutely. um, what would you say is one nutrient that is really underrated in pregnancy, maybe in the first trimester, in terms of feeling well? We'll talk about that too, but
Yeah.
what's one that's underrated that we really hardly ever talk about, do you feel?
Vitamin A.
Oh, okay.
Yeah.
Tell me
I
more.
think vitamin A is one of those nutrients that we have so much fear around that we forget that it's actually quite necessary in the diet, right? There's plenty of studies that link things like preeclampsia to low vitamin A levels. We find studies that show that in third trimester, there is a six-fold increase in vitamin A receptors in the uterus in the third trimester. And wouldn't you know it, vitamin A is required for the genetic expression of our oxytocin receptors. Kind of interesting, right?
I did not
So
know that.
yeah, most people don't. This is like one of my favorite topics. If we jump into labor and delivery prep and nutrition on that, it's so cool. But it's a specific form of vitamin A called the retinoic acid, right? Which is the active form of vitamin A. So we're not talking beta carotene here. We're talking actual active vitamin A. But you find there is, yeah, that six-fold increase of retinoic acid receptors in the uterus. And that's one of the jobs of retinoic acid is genetic expression of things. In this case, it happens to be genetic expression of oxytocin receptors. And super interesting. There's a thyroid connection there too, where thyroid hormones, a portion of thyroid hormones, is part of the conversion of the carotenes, the beta carotene, into retinoic acid. So there's this little triangle of stuff that happens there, and T3 and vitamin A kind of work together. Their little receptors are pretty close to each other on the nucleus in the DNA there for genetic expression. And there's study after study after study that talks about subclinical hypothyroidism in the third trimester being associated with longer first stages of labor, issues with transition. So a lot of these birth things that can very much be associated with maybe poor accepting of the oxytocin, right? Failure to progress, even with Pitocin. Well, if you give them Pitocin and there's nowhere for it to bind to, well, it doesn't matter how much Pitocin you give them, there's no receptors. It's kind of this interesting connection. Now, there's no research connecting vitamin A to these things yet, but understanding the physiology and the domino effect of things that happen, it makes it, for me, you talk about one of the most underrated vitamins, to me, that's one of them. And because it's so underrated and because we're so worried about quote unquote toxicity, which again, if we're going to have any sort of birth defects from a vitamin A exposure, we're talking preconception issues. That's where Accutane and some of these things pop in, or these synthetic vitamin A's that are associated with birth defects. You're not going to get that in the third trimester. Your baby's already developed. The research even keeps it kind of underrated because nobody's looking into it outside of, well, we knew this happened and we kind of forgot about it, right? We know that those receptors increase, but nobody's looking into what actually happens, right? So yes, I think vitamin A is one of the most underrated nutrients in maternity
That's
care.
so interesting. I love that. Okay, tell me more about this. So the vitamin A that you're talking about, are we talking about increasing vitamin A throughout pregnancy? Because I absolutely feel like retinoids, retinoic acid, etc., have been villainized from the Accutane situation. And so it's like avoid everything that has anything that looks like that compound forever and ever.
Yeah.
Never touch that, right? Like birth defect, like everybody's just like, nobody's gonna touch that, like you said. And even the research is like, well, like we think it's good for us, but we're gonna ignore it because, you know, this history that it has. So tell us what we should be doing in terms of, are we eating more vitamin A foods? What are we doing? And when are we doing that? Is this preconception? Is this with each trimester? Because I do think, right, like if your oxytocin receptors don't work, you're not having a baby. If you don't have them expressed, you're not having a baby. I mean, you are, but you know what I mean? The labor is affected so much, right? We talk about oxytocin receptor saturation with Pitocin use, things like that. So that is a key component. And then we talk about sort of oxytocin or Pitocin resistance with some conditions, things like that. So this is such an important role that this vitamin is playing. So how do we get our bodies ready for labor, and when do we start?
Yeah, so I typically tell people, and again, chapter 12 of my book is all about functional childbirth. It's actually the whole reason I wrote my first book was so I could have this one chapter and everything that leads up to this one chapter. Because I kept seeing in clinic, man, if we focus on the maternal physiology, forget baby physiology, forget baby nutrition, let's focus on mom, I think we can change birth outcomes. I think we can make moms have better, more functional births if we focus on what's happening in their body in response to that growing baby in preparation for labor and delivery, and support those physiological needs with the nutrients that are needed. And again, vitamin A is one of these for me. For some people who are interested, I actually have a downloadable ebook that is completely nutrition based. It's got a list of like my top 10 foods to add in the third trimester for preparation for labor and delivery, and it's on my website. But vitamin A rich foods become a part of that. And I think it becomes a blend. And I think every nutrient that has multiple sources, whether it's plant based or animal based, we need the blends. There's a reason we have these different pathways in the body. So we tend to focus a lot on our orange vegetables that have the carotenes in it so that the body can naturally convert them as needed into these retinoids and use them as necessary. But then we also want to consume the actual retinoic acids in the diet. And we get those primarily through things like skin. How many people eat skin, right? Remember the whole no fat diet thing, right? We want boneless, skinless chicken because it's straight protein. Man, you lose so much nutrition when you do that, right? And some of these fat soluble vitamins like vitamin D and vitamin A become some of these big ones that you lose that are found in things like chicken skin. They're found in fish skin, that wonderful gray layer on salmon between the skin and the meat. Oh man, that's magic, right? That's the good stuff. That's what you should be eating, right? That's where the vitamin D is. That's where the vitamin A is. So something as simple as changing your protein sources to be bone in and skin on, you're going to automatically get a little bit more of that. Then, of course, there's liver, right? The organ meat game. Liver is probably your biggest bang for your buck when it comes to those retinoids because that's where the body stores them. I think liver has a place, organ meats have a place in the diet. I think we have fear-mongered organ meats for long enough, right? And I think there is a nice little movement now where we're seeing people getting these in their diet more regularly. I also see people getting maybe a little overzealous with their organ meats too, right? I don't think you need to be doing it every day. Like let's go back to how we kind of did them beforehand. I think a couple of times here and there is just fine, right? It's all about balance. It's all about variety. The more variety we get these nutrients in, the less likely we are to end up with like single nutrient deficiencies. And that's something we see too when we're not getting enough variety and people are eating like the same thing over and over again, right? If they're just missing that one little thing, it may not happen right away where they get a deficiency, but over time and increased demand, if they're just not getting it because they're eating that same thing every day and it's just a slight insufficiency, eventually that becomes a deficiency. Just not because they're doing anything wrong, just because they're not getting the variety, right? So those would be my two easiest go-tos for the vitamin A component from that nutritional perspective, right? The orange veggies, for sure. I think sweet potatoes. Nobody eats pumpkin anymore, I feel like, right? Pumpkin is such a good vegetable, so nutrient dense. And most of the time when people I like mention, hey, maybe try adding some roasted pumpkin in, they jump onto the bandwagon like, oh my God, that was actually really delicious, especially with some good butter on there, some grass-fed butter that also has some good vitamin A in it, right? The dairy fats are going to be pretty good there too. It's a really good palatable type food, especially in pregnancy. I find a lot of people enjoy that, especially if they have got some tummy upset and some nausea. Pumpkin's really, really good at reducing any sort of gastric upset, right? We give it to our dogs when they have tummy upset, right? It does the same thing for us.
I think, yeah, I think those are great and actually easy things to incorporate. I feel like you could roast a bunch of orange veggies and have them kind of throughout. And then just the idea of like, okay, we're doing skin on chicken. It's funny that you said about the salmon. We were eating salmon and my daughter was like, this gray stuff, do I eat this gray stuff, Mom? I'm like, yes, it's edible. Please put it in just shovel it in. Yeah, absolutely. But
Uh-huh.
oftentimes we scrape that off, right? We're like, when
Mm-hmm.
it's not oranges, then how is it going to be? But I love that it's full of nutrients.
Yeah.
So that's amazing. What are your thoughts about supplements on this? We have the organ supplements.
Yeah. So I really was excited about, I feel like desiccated organ supplements when they first came on the market. I'm like, oh, this is so easy. So if I have a patient that I really need to bump this up on, we'll just do that. Clinically, I don't find them very helpful. I don't find them actually doing that much unless you're taking a ton of them. I feel like there might be something in the desiccation process that reduces either absorbability or we lose a little something in there. And, nutrition is super complex. We don't really even fully understand all of nutrition, right? We talk about vitamins, we talk about minerals, but we don't talk about the phytonutrients. We don't talk about how things interact together. And I feel like there's a whole world of nutrition that we just don't even know anything about. And so when you take something and you isolate it from its food source, I think there's a strong possibility that we miss something. We don't even know what we're missing yet. That changes the way our body either accepts that nutrients, uses that nutrients, or it takes that nutrient with it, right? So that all to say, clinically, I've never seen them actually do things. I've never seen them actually raise a nutrient level on paper. I think anecdotally, I have clients who take them and they feel better taking them. But on paper, as far as like, oh, I have somebody with iron deficiency and they want to use a liver capsule to try to bump up their iron, I've never seen it work.
Thank you for sharing that. Yeah, I haven't had great success either. So I was going to say, if you have one to recommend, I'll take it.
Yeah.
So yeah. Okay. I mean, we know that when we eat certain foods, all foods, right? The vitamins, the minerals, the phytonutrients are in that food in perfect proportion. You're not going to overdo it. You're not right. Your body's going to take what it
Mm-hmm.
needs, store what it needs, and then the rest gets excreted. Versus when you're taking single vitamin supplements too, you run the risk of now putting your body out of homeostasis. So
Yeah.
definitely, I think these are easy ways to incorporate vitamin A foods into your diet. So I love that. Can you walk me through a little bit about what a typical like functional pregnancy plan looks like? What does that encompass?
Yeah. Well, it depends on the individual, right? It really does. And that's what makes, I think, the functional maternity care so beautiful is there is no protocol. It shouldn't be, right? If you are creating a protocol, then you're really not doing true functional medicine. Functional medicine is individualized care and individualized medicine. So you might have a game plan of like, okay, well, at 12 weeks, I like to run these things because it helps me assess what's happening. But you may adjust that based off of the individual that you're seeing, their health history, maybe even some of their preconception history. And, where generally your next protocol might be to run labs at 28 weeks. Well, because this popped up here, I actually kind of want to run labs at 18 weeks. And I want to do this sort of protocol on you because you're unique and you don't actually fit into this pattern. And so a true functional medicine practitioner, in my opinion, shouldn't do protocols. They should have guidelines, not protocols. Like, here's my guideline, right? Here's my starting point. And from there, I have a whole schematic on, okay, if it's this, I'm going to go here. If it's this, I'm going to go here. And if it's this and this, I'm going to try to put those two together, right? That's my opinion on it. So for me, I don't really do protocols. Right? I have a couple things. Okay, I say that. But if I have a patient who comes in and they've contacted me, maybe I've been working with them preconception, like, oh my God, I got a positive pregnancy test. I have a couple things I want to test right off the bat because I want to assess how is that individual doing right now? What's my screenshot? Do I automatically need to start doing anything in treatment? Right? I'm going to look at her thyroid. I'm going to look at her progesterone. I'm going to look at HCG because that gives me a nice basic base on how is her body responding to the HC, how much HCG is getting produced, right? How's her corpus luteum handling it, and how's her thyroid handling that extra stimulation from that HCG. If everything looks good, then we might say, fantastic, I'll talk to you in 2 weeks. If anything changes, call me, right? If you get nausea, call me. Let's work through this. Understanding that physiology, we may ask a bunch of silly questions, what seem like silly questions, that give me an idea of, okay, here's all the possibilities. I go into morning sickness, Okay, here's your pattern. Here's your dietary changes you're going to start making. Here's an extra supplement maybe we try for a little bit. Oh, okay, let's cut out your prenatal for a bit and let's add this in instead, right? So again, there's guidelines. There's a starting point, and then there's whatever happens after that.
How much time do you feel like you spend talking about nutrition to patients?
Probably too much.
Yeah, me too.
Yeah.
Absolutely.
Because
It's
everything can go
critical.
back to nutrition. Everything goes back to nutrition. Diet and lifestyle is everything. What are they doing? I think one of the other things that's very underrated in maternity care is talking to people about their sleep habits.
Mm.
Nobody talks about sleep, right? I mean, every pregnant person, like, did your midwife or your OB, did they ask you what time you're going to bed at night? Especially when it comes to things like preeclampsia, right? Placental development, all these sorts of things. Uh, Anything that can be related back to oxidative stress and inflammation, the first thing you need to think about is how's their sleep. because that's how the body cleans out the everyday toxicity of life. And on pregnancy, we're asking the body to do an excessive amount of tissue recovery. There's an excessive amount of oxidative stress that happens just in a normal pregnancy experience. And she has to sleep in order to clean that up. This is why we're more tired when we're pregnant. This is a normal physiological change. I had one patient who I actually declined care to once because she was a bodybuilder and her whole focus of treatment was, I want to be able to lift and maintain my endurance during pregnancy. And I told her I can't guarantee that because the normal physiology is going to basically tell your body you need to rest more. You're not going to be able to do those things most likely. I can't make that happen for you. If your body is feeling overworked and underpaid, it's going to have to take a break. You're going to have more stress. Right? Being pregnant is like running a marathon every single day. It's a lot of physical tissue turnover. It's a lot of metabolic change. We just talked about earlier just the metabolic change of the first trimester where that metabolic system is just revving. That's a lot of energy turnover. You add more to that, running, exercise, that kind of stuff, depending on the individual, it might be too much for them. It's a hard one to balance.
I think we don't talk enough. I mean, I think maybe it's a cultural thing or a personality thing. You tell me, but I think women are expected to, I mean, this was my expectation of myself when I was pregnant. I was expected to, continue to do everything I did before, continue to
Mm-hmm.
work out, continue to work nights, continue to run without really, honestly, I wasn't paying attention to my nutrition the way I should have been.
Yeah.
I think it's that like societal maybe expectation that, you're when you're pregnant you're the same, you're just
Mm-hmm.
like have this pregnancy
Yeah.
condition, but you should be expected to do everything that you have been doing.
Right.
There's not that space for rest, and I think it's so important for women to like recognize that and accept that and allow that. For my type A personality
Yeah.
folks, for my go-getters, the bosses out there, managing businesses, etc., that idea, there's a reason why you want to lay down on the couch. I feel like for my
Mm-hmm.
first 3 months, like that's all I wanted to do is just
Mm-hmm.
pass out on the couch. And
Yeah.
it felt crazy. It
Mm-hmm.
felt absolutely like what's happening to me. And it was hard for me to accept that.
Mm-hmm. It's very hard. I feel like that first trimester switch and that hijacking of the maternal physiology, it is sometimes harder on the mental health than it is on the physical health because it is to some degree out of your control, right? It's the normal physiological change that's happening in your body to facilitate the growth of life. And it's exhausting. And it can be very hard to go from somebody who is very type A and very gung ho and oh my God, I go do all the events and then I like to go running and then I like to do this and I usually stay up until 10 or 11 to get other stuff done. And their body is saying, that's too much right now. You've got to pull back, right? And it's, this too shall pass, right? It's a temporary moment in life. And I think we don't tell women to give their body grace during this time frame. Sometimes their body just needs a hug, right? They need to give themselves a hug and just accept, I'm okay. I just need rest, right? I just need some downtime right now. It's kind of like being sick, right? If you have the flu, what does your body tell you? Shh, take a nap, right? You need to rest more. You need to have some downtime, right? Pushing yourself through the flu tends to make you worse, tends to make you more sick. It's the same thing in pregnancy. If your body is saying, I need a break, we have to listen to these signals. If it's abnormally telling you you need a break, then we need to look into why your body is abnormally asking for a break. There's a time and a place for those breaks in pregnancy. And then there's a time and a place when your body is that exhausted that that's not right as well. So we have to be able to listen to what the body is telling us, take it with some grace, and then also know what's that physiology at that specific time in pregnancy, and is this normal or abnormal? What is my body trying to tell me right now? That's
That's a
hard.
really good question to ask. Absolutely. And like you said, sleep is so critical. Going back to your previous comment about sleep, it's critical for the cleaning that happens when we sleep. It's critical for hormone production, for our GI repair, for
Yeah.
our mental, resetting, I should say. And so that it definitely becomes an issue, can become an issue in pregnancy when women are uncomfortable.
Yeah.
It's third trimester, you're up peeing half the night, things like that. So definitely something to assess.
Yeah. I can't tell you
Um,
the number of mamas who I have talked to over the years who bought lazy boy recliners in their third trimester because it was the only way they could get a full night's sleep was to sit and sleep on their backs in a recliner. And that was the magic, right? Oh, my hips. Oh, this. Oh, I'm such a back sleeper and I can't do it. They get a recliner and oh my God, it is literally night and day. And they're like, I can actually get a full night's sleep. This is amazing.
oh, absolutely. I have patients that do that too.
Yeah. I was like, I need to get an affiliate account with Lazy Boy at this point.
Absolutely. You talked a little bit about testing labs, talked a little bit
hmm
about thyroid. What role does lab testing play? And are there labs that you think like every pregnant woman should have? Um,
hmm Yeah. So I think labs are a window into the physiology. Are they perfect? No. Do they miss things? Yes. But it can also give us a lot of good information as to, snapshotting. How's your body working right now? Right? Are there things in your labs that make us scratch our head and go, we should watch that? Are there any red flags that may be predictive markers of future complications that we really need to address now? So of course, functional medicine, we use a lot of lab work in general for assessments because of that. I mean, symptomology is great, but sometimes symptomology lies. So having the symptomology with the snapshot of the blood work really can help give a really clear picture. As far as like my basics of things, generally on a prenatal screening, it's pretty basic. We're looking to see if somebody has STDs, right? Do they have anything bad going on? What's their blood typing? Sometimes we'll do a urinalysis and say, hey, do you have a UTI? And we do a CBC, checking for anemia. That's it. But if we added something like a comprehensive metabolic panel, checked out that thyroid, double checked that ferritin, looked at vitamin D levels, as a basic protocol, man, we'd get a huge snapshot, especially when it comes to what the research says about some of these labs as predictive labs in that first trimester, right? If you have somebody who already has like low ferritin in the first trimester, well, we better start working on that because it is normal for ferritin to drop 75% throughout pregnancy. So if they're already starting off low, and I think what does the study say? Anything 30 or less on a ferritin, we can predict anemia later on in pregnancy, regardless of the CBC in the first trimester. We know that person's going to end up with anemia at some point. Let's start working on it now, right? Regardless of hemoglobin, let's start working on it now. Let's make sure they're getting iron in their diet. Let's make sure that they are getting maybe an iron supplement if they need it. Same thing when you're looking at things like the comprehensive metabolic panel, not a basic metabolic panel, but a comprehensive metabolic panel where we can really look at the liver and kidney functions. If somebody already has elevated liver enzymes, we need to assess, is that their norm? Did they have that preconception? Or do we need to keep an eye on this because they're already showing liver strain? There's already tissue damage somewhere in the body, right? AST and ALT we think of as liver enzymes, but really they're a marker of tissue damage. It's just where's the tissue damage. You do find women who are weightlifters or are big worker outers. They tend to have higher AST or ALT or one of them because they have a high cell turnover, muscle turnover. Thyroid. How's their thyroid doing? Right? Simple thing. We see study after study after study. I think thyroid is one of my soapbox topics because I think as far as maternal physiology goes, the thyroid physiology is some of the most underrated physiology that nobody talks about, that has such a profound impact on pregnancy and childbirth outcomes. And nobody tests it. Nobody tests it. But if you tested it in the first trimester and we already had a TSH that was looking a little overworked and underpaid, we can predict you're going to struggle. And even though your thyroid might be producing enough thyroid hormones, eventually it's going to burn out. And you're going to be more likely to have a postpartum thyroiditis or a postpartum thyroid shutdown. Let's give it a hug. Let's see what it's missing. Why is it working so hard to get enough thyroid hormones into the system, right? That's just going to hurt you down the line. Is baby doing okay? Sure, baby's fine. But you're going to suffer. You're going to have a hard postpartum if we don't fix this now. You may have a labor and delivery outcome issue if we don't fix this now. Vitamin D is another one. I mean, again, talk about study after study after study. Vitamin D, I think I always joke, 2024 was like the year of vitamin D in research, where almost every single study that popped up was like, oh, vitamin D deficiency is associated with this. Oh, vitamin D deficiency is associated with this. And the most important time to treat vitamin D deficiency is the first trimester and first half of pregnancy. Once we get to third trimester, it's too late. It's too late. That placenta is developed, and it's all about the development of that placenta. When we're looking at placental development, we have kind of like two phases of placental development. We have the first phase, which is all that stuff that's really hormonally driven, and kind of we joke, it's like that preconception stuff that plays into it, that first trimester game. By the time we're 12 weeks, we have a small, very functional placenta, right? Second phase is taking this small, very functional placenta and turning it into a very large functional placenta. And there's a lot of vitamin D and hormonal work that happens in that phase too. And if we have a hiccup in any phase of that placental development, well, that's going to transfer into third trimester, where that placenta should be strong and capable of maintaining that whole third trimester until its lifespan finally gives up, which should time with baby's ability to breathe oxygen and the surfactant production and all of that stuff that happens. But if there's something that happens in that first half of pregnancy, it's going to be that second half of pregnancy where those complications rear their ugly head, but the actual dysfunction started then. And that's where vitamin D over and over and over again, you see vitamin D deficiency is associated with all these things, but if you treat their vitamin D deficiency in the third trimester, it doesn't do anything. So if we test it in the first trimester and we start treating it in the first trimester, we're going to have better success in that preventative care. And that's my basic, right? That would be a very, very basic lab protocol. Right now, again, depending on the individual, we're probably going to add more to that based off of their history, based off how their first trimester went. There's other markers you can find in those labs. Thiamine deficiency, for example. There's markers of thiamine deficiency in a comprehensive metabolic panel, and studies will show thiamine deficiency, when you know it, it mimics hyperemesis. And so for some women, their hyperemesis may actually be a thiamine deficiency, or it started off as nausea and maybe a little bit of hyperemesis, and then just not eating well for a few days starts to throw them into a thiamine deficiency, because thiamine is a very sensitive B vitamin. We need a very small amount of it, but we have to get it every single day. And so a few days without it, and we very easily fall into a deficiency type pattern. You add weeks of vomiting on top of that, and it becomes an exasperation. And you can see that in a comprehensive metabolic panel. There's biomarkers of that. Same thing with a B6 deficiency. You can see biomarkers of B6 deficiency very early on in pregnancy. And regardless of iron levels, if you have a B6 deficiency, that's going to cause low hemoglobin production, because B6 controls the rate limiting step in heme production. So just right there in that first trimester panel, you just set that woman up for much better pregnancy success by looking and assessing the basics of her nutritional status and her functional status. How's her body working?
Absolutely. And it's not a big amount of lab. I mean, it's not a lot of labs. I feel like that's a pretty standard thing, but adding the comprehensive metabolic panel absolutely gives us a lot more information. How are you working on the deficiencies, on the vitamin D, maybe the thiamine, thyroid? What are you doing to support the processes?
Sure, we're doing a combination. We're doing a combination of supplementation and nutrition, right? The goal is always, how do we get it in the diet? But there's a time and a place for supplements. If somebody is actually in a deficiency phase with a nutrient, they're probably not going to diet their way out of it fast enough. So we have to add a supplement to boost that up, right? So we can get them out of that negative pattern faster, because pregnancy is very time sensitive. We don't have a lot of time. We can't supplement for 3 months or do diet for 3 months and then retest and say, well, were we able to get you up and out of that? Because that's, it takes a minimum sometimes of 3 months of dietary work to fix a nutritional deficiency. It doesn't happen overnight, and it doesn't fix overnight. So in pregnancy, that's where those supplements come in, is we can give them that little boost, right? And sometimes if it's like morning sickness, thiamine stuff, we may even go straight to IV nutrition. Let's bypass that tummy. The tummy is not happy right now. Let's put some B vitamins in your bloodstream via an IV and get that big bump up, right? So that we can get you out of this vicious cycle faster. And that's one of the things I always, oh man, sometimes it just makes me cringe. Sometimes I have mamas who have hyperemesis and they go to get hydrating IV. But man, if you threw a couple vitamins in there, you would have just souped up that hydrating IV to be an actual functional IV. Not only are we getting hydration, but we're fixing any sort of nutritional deficiency that might be happening in that hyperemesis situation to prevent the complications that are higher in people with hyperemesis. It's a simple
100%.
change.
It's like you're doing a bag anyway, just throw in the vitamins and the IV. I love that. And absolutely, I think it's pregnancy requires higher levels of these vitamins. And so
Yeah.
really working on nutrition makes it really complicated, especially in that first trimester.
Mm-hmm.
Um, I think nausea, vomiting in pregnancy studies show that 50 to 80% of women experience nausea and vomiting. And really it's a time that, a lot of people don't know you're pregnant, you're still you're working, you're
Mm-hmm.
doing your regular things. And on top of that, you're having the fatigue, maybe the food aversions and nausea, vomiting. What what is going on when that's happening? You mentioned the thiamine deficiency, so
Mm-hmm.
that's one. And then what do you do to help women through it? What
Yeah.
food, supplements,
Oh,
dietary changes, lifestyle, I mean, all of it, right?
right.
What are you
All the things.
doing to
Yeah.
help? Yeah.
Well, it goes back again to that physiology. What's the biggest driver of what's happening on the maternal side is that revving of the engines. So for some women, they find that it's this mixed bag of, oh, if I eat a big meal, I get more nauseous. But if I don't eat, I'm nauseous. And I can't find that right balance. And it's trying to help them find that balance where it's like you have to eat something, a small something. Sometimes it's every 30 minutes, right? And it needs to have some carbohydrates in it because your body's blowing through carbs. And I know when I say carbs, I mean, carbs already are like this negative connotation. Everybody thinks, oh, well, sugar's bad for you. I'm like, I didn't say sugar. Now, I have the saying where I say sugar grows babies, right? That's my saying in the first trimester because glucose, the absorption of glucose increases in the first trimester. The production of insulin increases in the first trimester, and insulin sensitivity at a cellular level, particularly the endometrial tissue itself, increases. So we're getting a huge drive of blood sugar, and then we're getting a huge suck of blood sugar into those cells, right? So our ups and downs can be extreme, but we need those sugars to grow our babies and our placentas. Well, our placentas, right? Not our babies. We're not really getting much to them. So it's this game of giving the sugars, right, which is just calories and carbohydrates. That's why we're craving that. But doing it in a controlled way, pairing it with a protein, so that we're getting this control of the absorption of the glucose. So we're raising it as needed, knowing, oof, we're going to suck that down real fast, right? So some women have to eat literally something every 30 minutes to maintain that nausea. And if they go past that, oh, they start to feel it pretty quick within an hour. They're like, oof, I was doing good after I ate, and now it's on the verge, right? And then they kind of don't even want to eat anymore, but they have to kind of put a little something in there. So some of the things that we find, and again, some of this is research based and some of it is just anecdotal, is that, I'm sure everybody has heard the study where they're like, oh, a high protein diet is really good for nausea, right? If you look at what they considered a high protein diet, they did scrambled eggs with vegetables in it, with a side of fruit and a piece of toast. That was their high protein diet. And they compared it to powdered lemonade. That was the study. And I look at that and go, you compared a balanced diet to shitty synthetic processed sugared lemonade, right? That's a
That's
horrible
not a
study.
comparison.
That is not a
It's not a
comparison.
study.
That's not a study. Take a balanced diet and compare it to somebody who just ate straight protein. Then tell me a protein diet was better. But the diet that seems to help is something like that. You need to have some proteins with some carbohydrates, right? a nice blend. This is why I always joke a bagel and cream cheese goes a long way in the first trimester. And I'll have people tell me all the time, yeah, no, that was the spot, right? I had a half a bagel and cream cheese and I felt like a rock star. And then I had another half 45 minutes later, right? It's because you've got that carbohydrate plus the fat and protein from the cream cheese. Now, I'm not advocating everybody just live off of a bagel and cream cheese diet. It's an example. There's a healthier way to do that as well, right? Where we can get a lot of those, again, the carbohydrates that we'd eat, fresh fruit, right? What is one of the things that we do see being beneficial for people with hyperemesis from a food perspective is watermelon. There's actual studies that show that women who consume watermelon have a reduction in their nausea in the first trimester. It's hydrating, it's got electrolytes, and it's got a lot of sugar. So it's kind of hitting that aspect of things a little bit. A lot of women find that dairy works really well in the first trimester. I'm not sure, have you seen like the cottage cheese blender pancake recipes?
Oh yeah. It's
Yeah,
all over
yeah,
social media now.
yeah, exactly. It's like cottage cheese, eggs, butter, and a flour of choice, right? And you blend it and you make pancakes with it. That has been something I've seen work really well for women with nausea. I have one of my clients who had hyperemesis with every one of her babies. I think we were on baby number 5 or 6 at that time. And the whole first trimester, every meal she had her cottage cheese pancake with something else. She was like, I crave these things, right? And then she'd put maple syrup on it. She'd have a big bowl of fruit. And this is what kept her from throwing up in that first trimester. So again, it's this game of getting the carbohydrates, getting those sugars, preferably from something like a fruit base or, some good quality carbohydrate, and pairing it with the proteins. The other thing we find is that generally red meats become a huge aversion in the first trimester. And this is because of the iron component of red meat. Iron absorption drops significantly in the first trimester. Outside of pregnancy, we see that animal-based iron absorption is about 35%. Plant-based iron absorption, 5 to 15%, maybe a little bit more, depending on the food source, how you're cooking it, those sorts of things. In the first trimester, iron absorption drops to a flat 1 to 2% across the board, regardless of the type of iron you're consuming, because iron is actually quite toxic, right? Iron is rusting, it's oxidative. This is why we sequester it in ferritin, is to protect our bodies from too much iron. And it's extremely toxic to our little babies. So right around that time frame in which the spiral arteries begin to open, we actually see we want a drop in the amount of iron in the bloodstream. Now, we don't want to be anemic. We want lots of good red blood cells because that has oxygen. We don't want free-floating iron or even transferrin-bound iron in the bloodstream. So the iron absorption drops until those spiral arteries open, that fresh oxygenated blood gets into baby, and we can pull out all the oxidative stress that baby has accumulated during that embryonic development phase. Once that feels nice and balanced, our body goes, poof, all right, let's open up that iron absorption again. For a lot of women in the first trimester, the iron in their prenatal causes nausea because their body is blocking that absorption, and is well established that iron supplementation causes nausea if you're not absorbing it. So for a lot of women, I'll say, hey, stop your prenatal. I find that for some women, their nausea is triggered by too much of something versus too little of something. And when our body is exposed to a toxin of some sort, well, I mean, if you've ever had a food bug, you know exactly how that feels. It feels a lot like morning sickness, right? And it is a natural mechanism to get rid of toxins in the body. And if we talk about GDF-15, well, GDF-15 is this hormone that has been associated with nausea. And what it does is it triggers a part of the brain that is associated with toxic vomiting. It exasperates the actual natural mechanism that tells your body to eject a toxin. Same mechanism of chemotherapy nausea, right? It's the exact same process. And so sometimes morning sickness is our body's way of saying we have something bad and we need to get rid of it. Let's just figure out what's the bad thing, right? Sometimes it's iron. That's why we have that aversion. Sometimes it's iodine. Well, our thyroid is being revved like crazy, which means we get a buildup of iodine in the system. Yes, we need it because that thyroid's being revved, but there are a few studies that link hyperthyroidism. Well, actually, there's quite a few studies. What is it? 75% of hyperemesis cases can be associated with a specific thyroid pattern gestational or was it transient gestational thyrotoxicosis, which is basically a temporary hyperthyroidism that happens just in the first trimester in response to high HCG. And we can treat that by reducing iodine. Right? And so it's interesting that we see these interesting connections and mechanisms kind of at play that we can use to our advantage in the treatment of those different types of nausea. And it's just figuring out that individual in front of you. Well, what's this person's pattern? What is the trigger of their specific nausea? You see the same thing with people with certain gut pathogens or gut dysbiosis patterns. Same thing. Our immune system gets suppressed in the first trimester because we don't want to attack anything, because our babies are like little parasites in our body, and it's the same mechanism. So our body suppresses our immune system so we don't attack the placenta as it infiltrates the uterus and causes a bunch of tissue damage. Because of that, that leaves an opening for any sort of pathogenic bacteria in the gut to grow and fester. And sometimes that in and of itself triggers nausea because the body is like, oh, this doesn't feel good. I don't like this, right? And it's natural reflex when we have a gut bug, well, that's to vomit it up or, go out the other end. So again, understanding all of these potential, again, the rabbit hole, right? Okay, we have this. Well, do they have this? Do they have this? Do they have this? All of those different rabbit holes change how you're going to treat that patient. Maybe it's a probiotic or fermented foods. I've seen sauerkraut juice work really well for morning sickness. Not the sauerkraut itself, but just sipping on the juice.
I like that tip. I like that. What are some common mistakes that women make? I think you alluded to not eating frequently enough, but what are some common mistakes that you feel like women make during this nausea vomiting phase
Yeah.
that make things worse?
I would say trying to force the continued paleo diet becomes a big one, right? That's one that I'll see a lot. And we're like, you got to eat the carbs. Like, just embrace it, eat some fruit, right? They're letting their brain take over versus listening to their body. And then I think the biggest one is that not eating enough, like not eating frequently enough in pregnancy, where they're sticking to their 3 meals a day like they've always done, but their body really needs maybe 7 or 8 small little meals a day, not snacking enough. Then sleep plays into it too. Right? Again, if we already have a little bit of a toxic sensitivity, if you don't get enough sleep at night, if you're not listening to that sleep cue where your body says, nope, you need a nap, right? Maybe you're holding on to a little bit too much of the natural cellular toxicity. Maybe you have an issue with, your detox pathways and you're just more sensitive to that. So you have to listen to that lifestyle aspect as well.
Yeah, absolutely. Absolutely. If So this is a stepping back question. If you could be in charge of maternity care in the United States for a day and could redesign the prenatal care system, what is the first thing that you would change?
Oh gosh, I think it would be better prenatal screenings. I think you have to start at the beginning. Right? Everything else is just acute crisis management. But if we can get women to get proper screening from the first pregnancy test versus waiting till the first trimester is already over, we're already going to be making better birth outcomes. If we can assess the maternal physiology from day one, we're going to make better pregnancy and birth outcomes. Thyroid health, progesterone health, all those things. That would be my
I
number one
agree.
thing.
Yeah. I mean, you got to start early. You got to intervene early and support.
Yeah.
How much do you think nutrition can shape the labor and birth experience? And I think we're going to have a whole episode on this. We're going to have you back, and we're going to talk about all about labor and birth. So I'm excited
Yeah.
if you don't mind. But just a snippet of what do you think? How do you think nutrition can play a role?
Oh gosh, I think nutrition plays so much of a role from the maternal perspective. Is there a good statistical number? No, because nobody's looked at it. Right? I wish we had good statistical numbers to say, oh, if we focus on nutrition, we can prevent, 75% of inductions or whatever it happens to be. But we can't. But if you understand the physiology of pregnancy, the maternal side, the connections between, baby placenta and mom and what's happening in that third trimester and how it all plays into labor and delivery, we can make bigger changes than what we've been told. And the preparation for labor and delivery doesn't start at 36 weeks. It starts closer to like 26 weeks. And it starts with changes on the maternal side that are all microscopic, which is kind of cool, right? So if we can focus on supporting her body through that transition and that buildup of hormones as the baby grows, we can set her up for that success in labor and delivery. And again, this is where functional medicine, I think, shines, is because, and especially the maternity functional medicine, because we're focusing 100% on mom's physiological changes, because it's going to be the third trimester where her body is making these huge changes that are all like internal and microscopic and just at a cellular level. And baby is just putting on some pounds and growing and maturing and all of that. And it's not that rapid development in those things that we saw, let's say, first trimester that we really needed to focus on from a baby perspective. And I think, again, chapter 12 of my book is all about that. This is how nutrition has the potential to change childbirth outcomes, because I think it really does once you understand that physiology.
I love that. Thank you. If a pregnant woman had just 20 minutes a day to invest in her health, how would you tell her to spend that time?
Oh man, like that's a tough one.
Because I think women, you know, they feel like I don't have a lot of time for this. I don't have, the energy. I can't read another
Yeah,
book.
yeah,
What's something that they get? I mean, I think the vegetables, the vitamin A we talked
yeah,
about, like, let's go. Like, we're going shopping today. I think
yeah.
that's easy, but what would you
Start
say?
small. Start small. Break it into small, manageable tasks. When I work with somebody from a nutritional perspective, my goal isn't to revamp their entire diet. It's to help them make what they're doing work better for them. Because it can be overwhelming. Nutrition is the hardest, it's probably the hardest thing to change when it comes to our health, is what we're eating on a regular basis. We get stuck into certain patterns from a nutritional perspective. Oh, I like these foods. These are comforting foods. Or we don't want to learn how to cook anything new, right? I can't cook that. I don't know how to cook that. You want me to do liver? Oh God, like I can't. I've never done that before. So the idea from my perspective is, how do I make somebody's diet work better for them? And that might be little changes, such as, well, I want you to focus on getting more fresh herbs in your diet, right? Oh, I saw that you did, a Mediterranean bowl the other night. Okay, well, instead of just doing rice, do a quinoa tabbouleh, right? Make quinoa, throw a bunch of veggies in there, whole head of parsley, right? You've already bumped that up. Ooh, you did some grilled chicken, throw some rosemary on there, right? Sometimes adding in simple little things make a more profound difference in their nutrition than trying to give them a 7-day new nutrition plan of things that they've never done before.
Absolutely. I think pregnancy can be overwhelming already. And I
Yeah.
think the little changes, little tweaks to what we're already doing, whether you're pregnant or not, I think
Mm-hmm.
in terms of change, it starts at the smaller level. What do you think is what do you wish that every woman had in terms of a tool or a test that they had in pregnancy?
Hmm. That's a tough one too. I would say, as far as testing goes, it would be that whole prenatal panel that I talked about earlier. I would love to see every single pregnant woman have a basic yet comprehensive prenatal screening. Because I think if we did that simple change, we would catch so many complications before they became complications, and make those small changes that make a profound difference on placental development and maternal health, and set that person up for better success in that second half of pregnancy.
Yeah, absolutely. I agree. What's one patient story that still gives you chills about the outcome that you helped to create? Do you have one of those,
I
or
do
many
have
of
one,
those
actually.
potentially?
I actually have quite a few that are just like, oh, okay, this makes my heart happy in so many ways. But golly, well, where do I start? I think a lot of the ones that are the most profound to me are the ones in which we either acutely reversed preeclampsia for them or prevented preeclampsia in future pregnancies. Right? I can think of two right off the bat. One was a patient of mine who was a first time mom, and she ended up developing HELP syndrome at about 28 weeks. And it was this game of how long can we keep you pregnant, and I gave her options. Like, she was in a midwifery care situation. They transferred her obviously to OB care. She had mild hypertension at the time, but it wasn't bad. They were waiting for proteinuria, all that kind of stuff. But her blood work was pretty scary. Her platelets were, less than 130. She had elevated liver enzymes, right? She also had high hemoglobin levels, which is kind of one of these unique presentations. And I kind of went with her and I was like, hey, like, here's what I want to do with you. I have no research to support this as a treatment option. What do you want to do? Are you willing to try this? And she said, I'm willing to try anything. So we did the specific protocol and started watching her blood work every week. And every single week, her labs got better and they got better and they got better and they got better. And she went to term. She went to 40
amazing.
weeks, right?
That's
from
amazing.
26 weeks on. And I always joke. And her OB said it was a lab error.
No, come on, no.
Yeah, that it must have just been a lab error. But her blood pressure got better, right? And all of her liver enzymes corrected. And so that's always one that gives me chills. Like, and that was one of the first patients that I saw from that preeclampsia perspective way back when, that I was like, oh my God, we can do this. We can do this with nutrition, right? It's not an inevitable death sentence of a diagnosis, right? With the right treatment and individualized care, we have the potential to reverse this. Why are we not doing this? It's one of my first patients that I started working with when I started doing pregnancy care. And to this day, I mean, I'm good friends with her to this day, right? As far as we go back and forth. And that was a big turning point for me as I was coming into this field. Like, we got this. We just need to learn it and explore it and research it. So that was one of them. Oh gosh, I just drew a blank on one of my other ones. Oh, another hypertensive case. I had a case that was a patient of mine who everything actually looked really good. And at 36 weeks, she had a spike in her blood pressure. Now, this was a patient who had been previously diagnosed with hypothyroidism. She was on hypothyroid medication. We had tested her thyroid at 34 weeks. On paper, everything looked good. 36 weeks, her blood pressure popped up. Her doctor ran some additional labs, preeclampsia screening type stuff, comprehensive metabolic panel, that kind of stuff. And I'm looking at them and I go, man, your labs really look like you're hypothyroid. And we hadn't tested her thyroid at this point. And I'm just looking at the way her white blood cell counts look and the way everything looks. And I'm like, I almost think your thyroid crashed. I know we just tested it 2 weeks ago, but man, thyroid hormones play into the way your white blood cells are developed. They play into protein metabolism and everything patterns like you're hypothyroid. Humor me. Let's retest it. And we retested it, and her TSH had gone from a 0.9 to like a 6 point something.
Oh, wow.
And her thyroid had crashed. And so she increased her medication, and wouldn't you know it, her hypertension went away.
Amazing.
And her OB had kind of fought her, like, well, we just tested your thyroid. Why would we test it again? That's not what's happening here, right? You have preeclampsia. We're going to deliver at 38 weeks, right? That's our plan. And as soon as she adjusted her med, everything was fine. And she went to 40 weeks.
That's amazing.
So these are those stories that you look at and you go, if we just understand those changes, if we just do the testing, right, and assess, especially these preeclampsia cases, maybe we can fix this. Maybe we can make changes. Now, this isn't going to be every case, obviously, but maybe we have the potential to reduce these negative statistics, to actually help more women have better pregnancies and better births by looking at it through a functional medicine lens.
Oh, I love that. I love that. Finish a sentence for me. Ready? When a woman feels informed and supported during pregnancy, she
succeeds.
I love that. I love that. Ooh, some really good stories. I appreciate that. Let's do a quick rapid fire round. How do you feel? Yeah,
rapid answers are usually not my forte, but we'll do our best.
Neither are mine. I was trying to do them myself, and I'm like, this is
What would
going
I
to
do
take
there?
me an hour. Okay, ready?
Hmm.
Choline or DHA?
Choline.
Okay. Favorite pregnancy book?
That's a tough one.
I know.
Hold on, let me think. Um, oh, you put me on the spot. I have so many good ones, and I'm trying to think of what is it, Lying In? Yeah, it's like the history of birth. Yeah, I like that one.
Okay. Food that you tell people to avoid?
Well, processed anything, particularly processed sugar.
One supplement that you swear by?
NAC.
Ooh,
I swear by it in certain scenarios. It's kind of one of my go-tos for certain things.
it's a big one. I love
It's a
that.
big one.
It's so important for women to take an active role in their health and their pregnancy, in supporting their bodies. And we've talked a lot about that today. We've talked about nutrition. We talked about nausea, vomiting, preeclampsia, thyroid health, everything, how it's connected and how intricate it is and how important it is for women to stay informed and really to support themselves. We do have a tradition on the Life Optimizer podcast where we leave each episode with the Life Optimizer challenge. One thing that people can do over the course of this week to change something in their life about what we talked about. Do you want to give us one, or do you want me to take a crack at it?
I can give one. I
Yeah,
think
let's do
that
it.
I would say if you are going to bed closer to midnight, go to bed 1 hour earlier. Just start that process of not staying up on your phone, staying up on in front of your TV until 11 plus at night. Just moving your bedtime up to about 10 o'clock over the course of time, you're going to start to feel so much better. And it's that one little change sometimes that makes a difference in your health outcomes.
Well, you just spoke to Viktoriya in every pregnancy she's had. You just spoke right to me because I'm a night owl. I'm a recovering night owl,
Mm-hmm.
and that was a big problem. And I feel like being a shift worker as well
Yeah.
really messed with my hormones and thyroid and everything else. So I definitely agree that 1 hour, it doesn't have to be big. And even, I mean, I don't even care if you start with 15 minutes earlier. If you start at
Mm-hmm.
11:45 and then next week at 11:30, and
Yeah.
just scale that back, and make a promise to yourself to do it.
Mm-hmm.
I think that's really, really good. Our guest Sarah wrote a book, two wonderful books, and I want to read chapter 12, as that's all I know. I want to get going and read chapter 12. And so it has a lot of good information about nutrition and pregnancy. It's called Functional Maternity, and we'll link it in the caption below. Sarah, you have shared so much amazing information with us. Where can people find you online to really connect with you, to get more information, more informed, maybe work with you? Will you
Mm-hmm.
share that?
Yeah, the best place to connect with me is actually on Instagram. I am on there pretty frequently. I do a lot of posts that are research-based information for both practitioners and pregnant women. It's at functional.maternity. You can also visit my website, functionalmaternity.com. I offer continuing education courses for midwives and practitioners. And then I also have my private practice, which you can find a link on there to access the private practice.
Thank you so much for being with us. Remember, tiny changes make a whole new you. And we are so glad that you were with us talking about all of that. We will see you guys next week.